Welcome back, everyone, to the deep dive. This time, we're going deep on ulcerative colitis treatments.
You got it. Specifically for those moderate to severe cases.
We're looking at some pretty intense research here.
Straight from the American Gastroenterological Association, their 2024 Living Clinical Practice Guidelines.
It's a lot to unpack, but hey, that's what we're here for, right?
Absolutely. We'll break it down, highlight the key takeaways, and, maybe uncover some surprises along the way.
I'm sure we will. So what jumped out at you first when you dug into this?
Well, I gotta say, the sheer number of medications now available for moderate to severe UC is pretty remarkable.
Really?
Oh, yeah. This guideline covers everything. TNF antagonists, anti-integrins, anti-IL-23 antibodies.
Okay, pausing right there for a second. That's a lot of, what are those acronyms?
You got lots of acronyms, and that's not even all of them. We've also got S1P receptor modulators, JAK inhibitors.
Okay, so basically what you're saying is there's been like an explosion of treatment options.
Exactly. And it's a good thing.
Right.
But it can also be overwhelming, right, to try and make sense of it all. That's where these guidelines come in. They actually help categorize these medications into what they call efficacy buckets.
Efficacy buckets. Okay, I gotta ask, what in the world are those?
Think of them as like levels of how well these medications work, based on all the research, of course. So you get your high efficacy bucket, your intermediate bucket, and then the lower efficacy bucket.
So it's kind of like choosing the right tool for the job. But in this case, the job is managing, you see.
Precisely. And choosing that right tool, well, it depends.
On what?
Several things, actually. Like, are you new to these advanced therapies? Have you already tried some? What are your individual risk factors? Even how you prefer to take your medication, like IV, injection, pill, all of that comes into play.
Okay, so it's not just about picking the, strongest drug, right?
Not at all. It's more nuanced than that. It's about finding that sweet spot, the best balance of effectiveness and safety for each person.
Makes sense. Now, you mentioned biosimilars earlier. What are those again, just to refresh everyone's memory?
Sure. Biosimilars, they're basically highly similar versions of the original biologic medication.
Like a generic version?
Kind of, but for biologics.
Yeah.
And they've been getting a lot of attention lately. Some people might be a little hesitant to switch to a biosimilar, thinking maybe it's not as effective. What are your thoughts on that?
And I think that's a valid concern. Are they truly comparable to the original medications? That's a big question.
And research has shown that, yeah, biosimilars are just as effective and safe as their what they call originator counterparts.
Okay, that's good to know.
And there's another plus. They often come with a lower price tag.
Oh, so more accessible.
Exactly. More accessible for a lot of patients, which is huge. And speaking of accessibility, I noticed the guidelines mention subcutaneous formulations for some medications.
Subcutaneous formulations, what's that all about?
It means instead of going in for IV infusions, you might be able to take your medication at home with just a simple injection.
Oh, wow. That's a game changer for a lot of people, I bet.
You bet. Infliximab and vedolizumab now have subcutaneous options available.
That's got to be a relief for so many people.
Absolutely. Now, of course, sometimes, like if you've got severe disease, your doctor might still recommend, maybe, an extended induction regimen or a higher dose. And in those cases, IV might be more practical.
Makes sense. So again, it depends on the individual situation.
Always, always, always.
Now, before we get too deep into these advanced therapies, what about those older medications, like thioprines and methotrexate? Where do they fit in with all these new options?
Good question. So thiopurines, they've traditionally been used to help maintain remission, prevent those flare-ups once things are under control. But the guidelines, they actually suggest against using them for that initial push to get the disease under control, what we call induction of remission.
So they're not like the first line of attack, but more of a long-term strategy.
Yeah, you could say that. Now, methotrexate, that's a bit different. The guidelines recommend against using it alone for both induction and maintenance of remission in moderate to severe UC.
Interesting. So it sounds like there's a shift away from those older medications, at least in certain situations, in favor of these newer advanced therapies.
Yeah, to a certain extent, I think that's fair to say. But, it's important to remember that thiopurines, for example, they're still valuable, especially in areas where resources might be limited.
How so?
Well, for one, they're affordable, and they can be taken orally. Those are two big advantages.
That's a good point. Now, I also noticed that the guidelines discuss combination therapy and de-escalation. What's the latest thinking on those approaches?
Well, combination therapy, especially combining a TNF antagonist like infliximab with an immunomodulator, that can be more effective than just using one medication. But as with any medical decision, there are always trade-offs.
Right. Trade-offs, like what?
Well, while combination therapy can be more effective, it also carries a higher risk of side effects. So it's about finding that balance, right? That sweet spot between controlling the disease and minimizing the risks. Now, for biologics that aren't TNF antagonists, there's still some uncertainty about whether adding an immunomodulator really provides much benefit.
So more research needed there.
Definitely.
So is there like a clear winner here between starting with maybe less intensive treatments and escalating if you need to versus like going straight for those heavy hitters, the advanced therapies?
You know, the guidelines actually suggest early use of advanced therapies, potentially in combination with immunomodulators, rather than taking that step-by-step approach.
Wow, that seems like a pretty big change from, I don't know, maybe what doctors were doing like 5 or 10 years ago.
It is a shift in thinking, and it reflects this growing understanding that, hey, early and effective disease control, that's super important.
So more proactive rather than reactive.
You got it. But of course, we always have to remember, right, individual patient preferences, the severity of the disease, those are always key considerations.
Right, personalized medicine, as always.
Always. It's not one size fits all.
Okay, so we've got all these new options. How do we even begin to choose? You mentioned those efficacy buckets before. Can you walk us through those and help us understand, like, which medications fall into each category?
Of course. So first, it's important to clarify that we're talking about adults with moderate to severe ulcerative colitis who are being treated as outpatients. And when we're talking about inducing remission, meaning getting your disease activity under control. The guidelines place infliximab, golimumab, fenilazumab, tufasitinib, upadacitinib, ustekinumab, ozanimod, etrasimod, risankizumab, and guselkumab in the high-efficacy bucket.
Oh,
So those are the ones with the strongest evidence for inducing remission.
okay. So those are like the heavy hitters in the UC treatment world. But we talked about those restrictions on JK inhibitors earlier. I see a couple on that list, tafasitinib and opadacitinib. Can you remind everyone about those restrictions?
You're absolutely right. We got to keep those FDA guidelines in mind. In the U.S., those JAK inhibitors, they're usually reserved for patients who haven't had success with or can't tolerate TNF antagonists.
So even though they're high efficacy, there's a specific way they're supposed to be used.
Exactly. Weighing the potential benefits against those potential risks, making sure they're used appropriately.
Makes sense. Now, are there any other medications that might be considered for inducing remission in this group?
Yes, the guidelines also recommend considering adalimumab, filgotinib, and mirikizumab. But there's a little caveat here. It's what they call a conditional recommendation.
Conditional recommendation? What does that even mean?
It means there's a little less certainty. You know, the evidence supporting their use is a bit less robust compared to those high-efficacy options. There might be more variation in how people respond, or maybe some uncertainties about long-term safety or effectiveness.
So there's still possibilities, but with a bit more caution.
Exactly. And that's where those individual patient factors we keep talking about really come into play. You know, it's not just about the efficacy category. Got to think about age, other health conditions, even personal preferences about how you take your medication.
Sounds like that conversation with your doctor is super important.
Absolutely. Shared decision-making is key. You and your doctor working together to figure out the best path forward.
Now, earlier we touched on the potential for a higher risk of infections with some of these treatments. Is that something that comes up in those conversations, especially for people who are new to advanced therapies?
Definitely. The guidelines actually point out that vedolizumab and the anti-IL-23 therapies like ustekinumab, mirikizumab, risankizumab, and guselkumab, they might have a lower risk of infections compared to TNF antagonists.
So if someone's really worried about that risk, those might be good options to bring up with their doctor.
Good point. And it's also worth mentioning that there's not a lot of data on the safety of JAK inhibitors and S1P receptor modulators during pregnancy.
Oh, right. I forgot about that.
So for women who might become pregnant, it's generally recommended to choose a different treatment option, just to be safe.
Makes sense.
Hmm.
Better safe than sorry. Now, what about patients who've already tried one or more advanced therapies? Does that change things?
It can. The treatment landscape looks a bit different for those who've already been down this road, especially for those who've tried TNF antagonists and haven't had success. The guidelines suggest considering a different high-efficacy medication, or maybe an intermediate one.
So the playing field kind of shifts based on your treatment history.
Yeah, exactly.
Hmm.
The recommendations are tailored to take that into account. For example, for those who've already tried TNF antagonists tufasitinib, upadacitinib, and ustekinumab, they move into the high-efficacy category for inducing remission.
Interesting. So the JAK inhibitors and ustekinumab become more prominent options in that situation, but I assume those same caveats about JAK inhibitor use still apply?
Absolutely. Those FDA guidelines are always in play.
Good to reiterate that. So what about the intermediate efficacy options for those who've already tried other advanced therapies? What are we looking at there?
In that case, the intermediate efficacy options include filgotinib, mirikizumab, risankizumab, and guselkumab.
Okay, so those anti-IL-23 antibodies we talked about earlier are still strong contenders in this group. And what about the lower efficacy options for those who've tried other therapies? Who's on that list?
For that group, adalimumab, vedolizumab, ozanimod, and etrasimod are considered lower efficacy options for inducing remission.
So vedolizumab, which was a high efficacy choice for those new to advanced therapy, is now in the lower efficacy group. What's the reason for that?
It all comes down to the data. While vedolizumab has a good safety profile, it seems to be less effective in patients who've already tried other advanced therapies,
Hmm.
especially TNF antagonists. It's like the disease develops some resistance in those situations.
So the order of treatments, the sequence of medications used, it really matters. It's not just picking from a list, it's about understanding the context.
Exactly. Treatment history plays a huge role in decision-making.
Now, are there any other factors we need to consider for those who've already tried other advanced therapies, besides those efficacy buckets?
Of course, those individual needs and preferences are still front and center. Things like age, other health conditions, and those personal preferences about how you take your medication, all that needs to be part of the discussion.
Right. It's about that holistic approach. Anything else?
Yes. The guidelines mention that for individuals who have had what they call multiple biologic failures, meaning they haven't responded to several different biologic medications, those lower efficacy options might take longer to show any benefit. So patience is key.
So managing expectations, understanding that the journey might be a bit longer for some people.
Exactly. And on the safety side, even though some studies suggest vedolizumab might be safer when it comes to infections, it's important to remember that not effectively controlling the disease can also lead to more infections. So that potential safety advantage has to be balanced against how well the medication actually works, especially for those who've already tried other options.
So many factors to juggle. It's a complex equation. Now, we've been talking a lot about these advanced therapies, but what about those older medications? The immunomodulators like thiopurines, do they still have a place in this whole treatment picture?
They do. In fact, there are some specific recommendations about thiopurines for those with moderate to severe UC.
Okay, I'm listening. What's the latest on thiopurines?
Well, the guidelines say you shouldn't use thiopurines alone for that initial, push to get the disease under control, what we call induction of remission.
Right, right. So not the first line of attack, but what about after that initial phase?
That's where they can be really helpful. The guidelines actually recommend using thiopurines to maintain remission once you've achieved it, especially if corticosteroids were used to get that initial control.
So thiopurines are more like the steady long-term support once things have calmed down a bit.
Exactly, helping to prevent those flare-ups. But, it's important to remember that thiopurines can have side effects. They're not for everyone.
Right. Personalized medicine is key. What about methotrexate? Where does it fit into all of this?
For moderate to severe UC, the guidelines suggest against using methotrexate alone, whether it's for inducing or maintaining remission.
So methotrexate is taking a backseat to other options for UC treatment.
Seems that way based on these guidelines. Now let's talk about combination therapy for a bit. Sometimes combining medications can be more effective than using just one, but it can also increase the risk of side effects.
Right. Finding that balance. What do the guidelines say about combining immunomodulators like thiopurines with those TNF antagonists?
Well, specifically for infliximab, the guidelines recommend using it in combination with an immunomodulator, rather than using either one alone.
Interesting. So teaming up is the preferred strategy with infliximab. What about adalimumab and golimumab?
For both of those, the guidelines also suggest using them in combination with an immunomodulator.
So across the board, adding an immunomodulator seems to be the way to go with TNF antagonists. Why is that?
The evidence shows that it leads to better disease control, and people are less likely to have a relapse. But, we got to remember, combining medications always increases the risk of side effects.
Right, the trade-offs. Now, what about combining immunomodulators with those newer biologics that aren't TNF antagonists? Any guidance there?
That's where things get a little less clear. The guidelines don't actually make a recommendation for or against combining immunomodulators with those non-TNF antagonist biologics.
So more research needed.
Definitely. Now, how about we shift gears and talk about de-escalation? That's reducing or stopping medications once someone's in remission.
I bet a lot of people are wondering about that. Who wouldn't want to reduce their medications if they could?
Right. But it's not a decision to be made lightly. For people who've been in remission for at least 6 months without needing corticosteroids and are taking both a TNF antagonist and an immunomodulator, the guidelines suggest against withdrawing the TNF antagonists.
So don't ditch the TNF antagonist just yet, even if you're feeling great.
Exactly. And as for the immunomodulator, that same scenario, the guidelines don't actually make a recommendation either way. We need more research to know the best course of action.
So some uncertainty remains about when and how to safely de-escalate treatment. Now, before we wrap up, I want to touch on step therapy again, starting with less intensive treatments and then escalating to the stronger stuff if needed. What's the latest on step therapy versus going straight to advanced therapies?
The guidelines actually recommend early use of those advanced therapies,
Hmm.
maybe with immunomodulators. Instead of that step-by-step approach, it's a pretty big shift in thinking. It really emphasizes the importance of early effective disease control.
So a more proactive approach.
Exactly. But of course, we always have to consider those individual patient preferences and the severity of the disease.
Right, personalized medicine always. Seems like the big takeaway here is that there's no one-size-fits-all answer.
Absolutely. It's all about finding the right balance between effectiveness and safety. And that balance is going to be different for everyone. These guidelines provide a good roadmap, but the best treatment plan is always the one that's tailored to the individual.
Well, this has been a really informative dive into the world of UC treatment. It's incredible to see how much the landscape is changing with all these new medications and treatment strategies.
It really is. And, while these guidelines offer some really helpful insights, it's so important to talk to your doctor. Have an open and honest conversation to figure out the best approach for you.
Couldn't agree more. It's about working together to find the treatment plan that offers the best chance of getting and staying in remission. And with so much research going on, who knows what the future holds? Maybe we'll see personalized medicine based on genetics or analyzing the gut microbiome really revolutionize how we treat this condition. It's an exciting time for UC research, and I think we have a lot to be hopeful for.